Good evening. Thank you very much, everyone, for being here this evening. I'm Jim Sturgis, Executive Director of Pioneer Institute, and I'd like to welcome you all to the 8th Annual Colby Hewitt Healthcare Lecture. And I'd like to start the program with a few thank yous. We already have our speakers. They're very anxious to get going, so we'll make this very brief. I'd like to start by thanking the Harvard Medical School for its hospitality, with a special thank you to Dean Jeffrey Flyer, who has been an important voice for healthcare reform. Our thanks to Pioneer trustee Chuck Hewitt, who's right here, very much for being here with Teak and the entire Hewitt family. We really appreciate your being with us, and as many of you know, tonight's lecture is named in honor of our past chairman, our longtime chairman, Colby Hewitt, who was involved heavily on the healthcare side as well as for 8 years at Pioneer Institute. I'd also like to recognize the many Pioneer Institute board directors who are here this evening. We thank you for your attendance. We'd also like to thank all of you who for many years have helped us to build a fund that allows us to undertake healthcare work. As many of you have noticed, over the past 4 or 5 years, we've been extremely active in this space, and we will continue to be, as it is, after education, our most important priority. I am also deeply appreciative to our sponsors. In terms of our sponsors for this evening, we have as gold sponsors Davis Malm and D'Agostine, attorneys at law, and we have Pfizer. We'd like to thank them very much for their sponsorship. Our silver sponsors this evening, Harvard Pilgrim Healthcare, the Hewitt family, Vermonters for Healthcare Reform. We appreciate your support, and also our bronze supporters for this evening, Appleton Partners, Fallon Community Health, and Seal and Bill Hicks. Thank you very much for being with us this evening. We appreciate your support. And of course, thank you to our participants this evening. We have an excellent program with David Cutler and Avik Roy, whose jousts, thrusts, and parries will be moderated by Nancy Kane. And I kind of like saying that, Nancy Kane moderator. I've never thought of you that way at all, Nancy. It's sort of troublemaker, person who asks really hard questions, a moderator, no. We are pleased to have you, and so pleased to have the impressive track record of this lecture. In the past years, we've been honored to host Regina Hertzlinger, John Kingsdale, Dr. Jeffrey Flyer, who spoke the day after the passage of the Affordable Care Act. This is for us a place where it's an open space. It's a space where you can have safe conversations, left, right, center, all kinds of perspectives on healthcare. There's not enough room in the public arena for those sorts of conversations. We're trying to make that available here. Over the past few years, we've actually structured the lecture not as a lecture, but as a debate. So, for example, we had Douglas Holtzik, who was a former director of the Congressional Budget Office, debate Jonathan Gruber, who is an MIT economist who was influential here in Massachusetts in developing the 2006 law and was clearly very influential in pulling together the Affordable Care Act. We had last year Donald Berwick, the former head of the Center for Medicare and Medicaid Services, and today a prospective gubernatorial candidate, who was debating Jim Capretta, a DC-based health expert who focuses on market solutions. And tonight, David Cutler versus Avik Roy, whose introductions will be made by Josh Archambault, Pioneer Institute's Director of Healthcare Policy. I really appreciate your work on this, Josh. I appreciate Pioneer's team for organizing tonight's excellent event, and we look forward to a very robust conversation. Josh.
Well, thank you very much, Jim. I have the honor of introducing our speakers and moderator tonight, but I wanted to just spend 1 minute and set a frame for our conversation tonight, which I think tonight's topic is one that's been bubbling in healthcare for years. And as our state budget and many other state budgets continue to be consumed by healthcare, it was 50% this past year and 40% projected for next year, just healthcare-related actions. Calls for action certainly have grown. But I think even more burdensome has been the weight of the increasing premiums on businesses, which reflects the cost of healthcare, especially on small businesses. Simply put, healthcare costs remain a vexing issue for us. Consider the Globe's coverage just this past week. On the front page on Monday, there was an article highlighting that insurance companies project that healthcare costs will grow 6 to 12% over the next few years after slowing for a bit here. Yet we have a new state law here in Massachusetts that tries to keep the growth level with state gross domestic product or below. You'll hear a little bit more about this tonight. I think we're all crossing our fingers hoping that our economy can grow the somewhat optimistic estimate that they have of 3.6% this year. Yet the very next day, the Globe editorialized that Massachusetts needed a waiver from a portion of the Affordable Care Act, which pertained to small group rating regulations. It said because it would spike the premiums for small businesses. The rationale was that we, as the Commonwealth, are leading the nation in our efforts to contain costs. Both of these seemingly contradictory trends are both true at some level. So you can imagine the tension that exists as we move forward. And tonight, that's what we're here to do, is to have a conversation about how to best move forward on cost containment. And with that, I'll give brief introductions to our speakers. You have some more information in your programs if you'd like to learn a bit more. But David Cutler is a professor of applied economics at Harvard, with secondary appointments at the Kennedy School and at the School of Public Health. He has served on the Council of Economic Advisors and the National Economic Council and has advised the presidential campaigns of Bill Bradley, John Kerry, and Barack Obama. He was a key advisor in the formation of the recent cost control legislation in Massachusetts that I just mentioned, and is a member of the Health Policy Commission that's largely responsible for implementing the law. Cutler graduated from Harvard University and has his PhD in economics from MIT. He'll speak first. And then Avik Roy is a senior fellow at the Manhattan Institute. He's a prolific writer and a blogger and has served as an outside advisor to the Romney presidential campaign on healthcare issues. Roy is the founder of Roy Healthcare Research, an investment research firm in New York. And previously, he served as an analyst and portfolio manager at JP Morgan, Bain Capital, and other firms. Roy received his degrees from MIT and went to Yale University School of Medicine. And finally, our moderator, Nancy Kane. She is a professor of management and the associate dean for educational programs at the Harvard School of Public Health. She directs the Master's in Healthcare Management program, and she teaches in the area of healthcare accounting, payment systems, financial analysis, and competitive strategies. She recently completed 2 terms as a member of the Medicare Payment Advisory Commission, and Kane earned both her master's and doctoral degrees in business administration from Harvard Business School. And with that, let's turn it over to Mr. Cutler to begin.
Good evening. Thank you very much, Josh, for inviting me. This is a terrific forum. And to Avik and Nancy, thank you for having me on the panel. I'm always, whenever I hear myself introduced in such a kind way, I'm always reminded of what my former dean once said about the economics department. You'll know why I'm glad he's no longer my dean. He said, if you took all the economists in the Harvard economics department and lined them end to end, that would be a good thing. So I will assume that probably a fair number of you agree with that, and try to give you a few thoughts without making you too upset. I want to talk a bit about state policies to reduce the growth of medical spending. We're going to focus a fair amount, obviously, on Massachusetts. But I think of this a little bit as the answer to the trivia question, what do Arkansas, Oregon, and Massachusetts and a number of other states likely in the next year or two have in common? And the answer, if that were the Jeopardy question, and Watson were answering it, the computer system Watson that's soon going to be diagnosing you, the answer to that is that they're all experimenting with state approaches to try and reduce the growth of medical spending for exactly the reasons that Josh laid out so well. And so I want to pick up on some of the similarities, show you a little bit where Massachusetts is and a bit about the philosophy behind it, and then talk about how an economist views it. Okay, so let me start off. What is going on in all these different states? It may be one of the few things that transcends blue versus red, which is that the budgets are being eaten up by healthcare. This was a chart that was put together for Massachusetts. For all I know, it was actually put together by Josh in the Pioneer Institute. But if not, it's certainly something that is completely reflective of what Josh said at the beginning, which is that if you look over any period of time, this is roughly the past decade, the growth of the state budget has been totally dominated by healthcare. Healthcare on the left has gone up, both state employees, mass health, every other source of healthcare. And how have we met that? Well, everything else has declined, ranging from public health to mental health and education, state aid, housing, and infrastructure. And so there's this sense that something has to be done, which really came to a boil, of course, in the recession when revenues are down and claims on the state government or needs from state government go up. So that's facing governments. Another thing that's actually facing state governments is, and it's exactly, I keep coming back to what Josh said because he was exactly right, which is that governments do not want to just shift costs. So there's particularly to small businesses or to big businesses. So there's an easy way to do this, which is to just pay less through Medicaid programs or state employees, or the federal government pays less through Medicare. The providers then mark up everybody who has insurance. And what you've effectively done is you've taxed people who have insurance and given the money to people who are insured through the public program. In fact, it's even better than a tax because it doesn't count as tax revenue for the government or spending for the government. It's someone else collecting the tax revenue and distributing it. That someone else is any of the hospitals around or physician groups or whatever it is. And states are getting sick of that in part because the people who are paying the tax are getting sick of it. It's not a very good way to run a medical care system, that is to have taxes that are out there and not being recognized and so on. So you need to do something that doesn't do that. And the way you're going to do that in most of these state experiments is you're going to have the state work together with the private payers. So immediately you've gone from a situation where what you worry about is the state budget to what you're worrying about is total medical spending, and thinking about how does one address the issue of total medical spending. The bad news is you've got a problem. The good news, to the extent there is good news, is that everything that we know is that there's an enormous amount of money to be saved without harming patients, and put it a little bit stronger, enormous amount of money to be saved while actually improving the quality of care that patients receive. So the best guess among health economists, and when I say this is the best guess, I mean that approximately 80% of health economists would roughly agree with the statement that about 1/3 of medical spending is believed to be wasted. That includes outright waste, like people getting infections in the hospital that then cost tens of thousands of dollars to treat that they never needed to get, and you could have saved the expense, to things like care processes that involve too much surgery when medication has been shown by clinical trials to be just as effective and safer, to things like missed prevention where a person then winds up needing acute care resources later on. All of those are examples in the care realm. They're examples in the price realm. Our Attorney General in Massachusetts has shown what is apparent to most any payer, which is that prices of medical services vary enormously. The price of a routine abdominal CT scan in the Commonwealth of Massachusetts ranges from $400 to $1,400. If you ask whether the $1,400 CT scan is any higher quality, what you will find is the answer is no. If you ask what is associated with it, it's market power and prestige of the institution and so on. Administrative costs are very high. The typical hospital in the United States spends 10 cents of every dollar it collects collecting that dollar, which makes it about 100 times less efficient than the typical company in America. And finally, there's an enormous amount of fraud and abuse. It's not believed to be a big problem in places like Massachusetts, but there are entire parts of Miami which are devoted to home health agencies. And if you invite them to a welcome to Miami sort of potluck thing, half of them go out of business right away. So there are all those problems in cost, and we ought to get rid of them. And the question is, how do you get rid of them? So let me tell you what it is that economics has to say about it, economics has to say about this, and what it is that's a little bit in the state law here and in other states. So I'll rank them in sort of order in terms of things that economists believe are important. I will actually assign names to them. The first strategy I will call, for lack of a better name, and it's actually quite a good name, the Charlie Baker strategy, named after Charlie, who happens to be here. Charlie Baker once told me, David, and then he said something you shouldn't say, but he said, David, name a business that ever got better without knowing what it was doing. Am I correct, Charlie?
Close enough.
Close enough. So, name a business that you ever got to get better without people knowing what they're doing. So the first obvious requirement is, since people do have very high cost sharing in a lot of circumstances now, give them the information that they're going to need to choose well. In Massachusetts, we have pretty well-functioning insurance exchange for individuals, somewhat less well-functioning for small business, although maybe getting better. We have plans which now give people much higher amounts of cost sharing, sometimes selectively. That is, you pay more if you go to a high-cost provider, sometimes just across the board, although Massachusetts is not a very big HSA or high-deductible health plan state compared to other states. What Chapter 224 does, and you'll see these in green as I go along, Chapter 224 requires that as of October of this year, insurers be able to provide real-time price and quality information to consumers about every medical service they might use and every place they might have it done. So you'd be able to see when your doctor thinks you need an abdominal CT, here's the list of places. They range from $400 to $1,400, or in your cost sharing, maybe from $20 up to $800, and here's what we know about the quality of them. All of the insurers, I know Roberta Herman is probably spending enormous amount of money on aspirin dealing with this new requirement, but it's a sort of first in the country kind of requirement that says you have to be able to give this information to people so they can decide what to do. Everyone believes that it's a very good idea, so that's the first strategy. The second strategy, which also does extremely well by the economic criteria, and I will call this, for lack of a better name, the Andrew Dreyfus strategy. Andrew is the CEO of Blue Cross Blue Shield of Massachusetts, and he has pioneered the idea that what we need to do is move payment away from a traditional pay for what you want, pay for services model into a more global or patient-centered payment system. Andrew has been a pioneer of this, so have folks up in Dartmouth at the Dartmouth Medical School, along with folks like Don Berwick, who ran CMS in the Obama administration, and Mark McClellan, who ran CMS in the Bush administration. I tell you that a lot of these are non-partisan, and I think you'll sort of see that going along here. One of the things we know is that there are a number of institutions across the country that are very efficient in terms of resources, that are very low cost, very high quality. Every single one of them, they don't agree on much. They don't all pay their doctors the same way. They don't all have the same IT system, although they do all have IT systems. But the thing that they do, every single one of them has taken themselves off the grid where you get paid more for doing more, and gotten themselves payment for taking care of people and doing the right job. And if you look at the sort of care protocols that organizations use, they'll say we have 20 steps for dealing with patients with heart failure. And by the way, 12 of those steps are things that we wouldn't get reimbursed for at all under a fee-for-service system. That system just is not at all where we need to be. What we need to be is with a global payment system. We had a commission in the state in 2009 that called for moving all payments onto a global payment basis for every provider, for every patient within 5 years. The law didn't do that, but it strongly encouraged the move by moving state employees and Mass Health onto this kind of system, and by encouraging what was going on in private insurers to spread this widely. So it's the general expectation that fee-for-service payment will become a small part of Massachusetts payment compared to other ways of paying that are more focused around doing the right thing for the patient, not doing more things for the patient. And so that's a second very, very big thing. Arkansas has already moved ahead with this. They're doing bundled payment episodes for a number of acute conditions. Oregon has done this with the Medicaid program. They got $2 billion from the federal government to invest in Medicaid with the idea that they'd pay coordinated care organizations a fixed amount. Those organizations would then be responsible for cost savings. The state of Oregon agreed to pay back the federal government over time at the risk of lower Medicaid payments if they don't meet the spending targets. So one way or the other, that's where everyone is going. Provide a little bit more payment certainty and provide more incentives for providers to do what they want to do, which is treat patients well, not chase the dollars. There are a few other things. I'll just go through them very quickly. Data sharing, it's an enormous issue. Most providers say, I'm happy to manage patients better, but I don't know where they're getting care or what they're doing. So in Chapter 224, we put in enormous data sharing provisions so that there will be immediate information on patient use, both in real time, that is which patients are in the hospital so you can know how to deal with them if you're a primary care doctor responsible for them, and after some period of time so that you can see which of your patients have you been doing well on, which have you not. Medical malpractice, this state has never been very big on being able to sue your doctor. The doctor's lobby is too strong. But we went even farther on that, which is to endorse what people are calling the Michigan model, which is a cooling off period, excluding apologies from admission in court, basically trying to get to a kind of disclosure and transparency model where when an error occurs, you admit it, you have some reasonable compensation right away, and you move on. What we know about this system in places where it's been tried is that you have fewer claims, lower payouts, and everyone's happier as a result. So the state has moved in that direction. Finally, administrative simplification, which is something that I care an enormous amount about, although it's very hard for a state to do. We've put in some things about simplified referral forms. Much more can be done nationally, and other states are doing a fair amount. For example, Minnesota has had very, very significant administrative simplification, but it's a sort of kind of trying to put our foot in the water and trying to do something here. All of these are part of Chapter 224. In addition, the state put a target around what it would like the growth of medical spending to be, and you don't have to be a genius to figure out what the state wants, which is that revenue coming into the state coffers grows at roughly the growth of the economy. So if you're worried about the state budget, you'd better have your spending growing at the rate of the economy. Or otherwise, you've got a problem. If your spending is growing faster than your revenues, you've ultimately got a problem. Notice you need an economist to tell you that. The economy is growing about 4% a year. Medical costs on average have been growing about 5.5% to 6% a year. Of course, private sector premiums have been growing more rapidly than that because there's been a cost shift from the government to the private sector. That's what, coming back to what Josh was saying at the beginning. So the target for the state was to make all of medical spending grow at 4% a year, not the state part, because then you're going to get cost shift, not the private part, because then you can't do it all as a whole, make all of spending grow at 4% a year. That was what the target was. The target was to do that by lowering it over time, and then trying to hold it there. Somewhat interestingly, this was not a big item of contention when the legislation went through. So most of the providers said, look, quite honestly, this beats what our internal forecast is about the revenue that we're likely to get over the next few years. So if you want to do this, that's fine. Make sure you give us the tools, and the tools are what I told you about. Still, it's interesting because even having this target with actually extremely weak enforcement, I'm on the commission that, quote, enforces it, and what we get to do if the target is not met is we get to order someone to produce a performance improvement plan. Okay. To the extent you're scared by a performance improvement plan, you're probably also scared by the tooth fairy. So it's not a particularly onerous thing, but what it has done is it's focused an enormous amount of conversation around this is the target that the state wants, how are we going to do it? And you're already seeing in the context of negotiations between insurers and providers, okay, this is the target, how are we going to think about meeting this? So actually, against all my better economic instincts, putting something out there, even if it doesn't have enormous enforcement, actually produces an enormous amount of very productive discussion and change. And so I think that's quite interesting. That is, the country is off to a fairly good head start in terms of thinking about cost savings. So as you can see, medical spending growth has actually declined over time. The spike in the early 2000s is when managed care insurers got much weaker, and so providers raised prices. Other than periodic episodes of raising prices, which people think is unlikely to happen again, or at least on that scale unlikely to happen again, medical cost increases have been slowing, and that's part of the reason why a lot of people, including in this state and in Arkansas and Oregon and any number of other states, are thinking, how do we lock this in? What do we do to lock this in? So, in fact, the sort of slowdown was taken as an example of why we should do the kinds of things more of the kinds of things that promote this, not in the heavy-handed regulation way, which actually no one wanted to do here or in most of the other states, but in the way of saying, what are we doing that's successful and how do we keep doing that? I am not going to claim that I have all the answers. Usually I do. Tonight I won't. I'm not going to claim that I have all the answers. What I will say is that if you look at the policy landscape for where healthcare reform discussions about costs have been, what the states, particularly Massachusetts, but the other states are doing is trying to hit a broad path of them. So what you often find is on the left you see sort of people who are single-payer fans, and on the right, people who want to give consumers a lot more sensitivity, whether it's price sensitivity when they go to the doctor, whether it's choice about insurers and letting insurance companies do the rationing for them. And then you see somewhat in the middle a view that says, no, we're not going to do single payer, but we're going to try and change payment systems so that we reward doing better things and not just more things. And what's interesting to me is that really Chapter 224 and a number of these state initiatives try to draw on all of these. And I think the philosophy behind it is I don't want to have to choose one single thing that I think is going to be the magic bullet. What I want to do is take stuff from here that's in essence the best of all these approaches and try and bring them together. That's what I think our state is trying to say. Josh raised the question of who is responsible for cost savings, and the answer, at least in the approach here, is it's not the government that's going to do it. What it's going to be is it's going to be the outcome of what happens when the individual sees his or her doctor, and what happens when insurers and providers come together and negotiate about fees and rate structures and all of that. And the way that I think of what our state is doing is saying to the healthcare community, if you folks really want to meet these targets, because we all care about them, we will provide the resources, however they need to be provided, that will help you do that. So if you want to do that, we will come and help you do that. If you don't want to do that, there's not much we can do. We can make you do all the performance improvement plans we want, and that will not do a damn thing. So if you want to do this, we will be there to help you. If not, the thing will fail. And that's, I think, where we are, is we've taken a bunch of different strategies and we've said, let's do these because this is where there was agreement, and we think as a community and as a set of experts that this will work. If it does, that's great, and we'll all share in the credit. If it doesn't work, we can't figure, it's just not going to work, and then we'll have to figure out what comes after that, and Lord knows that's not going to be very pretty at any level. Just look at what the federal government is doing now. So I'm going to stop there. That's at least a little bit of an overview. I hope it's been enough to make you think that we shouldn't eliminate the economics department, or me, just yet.
Hi, everybody. Thanks for having me here, and I can't say brave the weather because it didn't turn out to be that dramatic, and it is Boston after all. And I also want to thank Jim and Josh for having me here. I, as you know now, attended the safety schools of MIT and Yale, and so I'm not necessarily worthy of sharing the stage with Professor Cutler, but I promise to do my best.
Give that man a degree.
That is true. That is true. We do have one alma mater in common. So David, I think, just did a great job of describing a lot of the policy initiatives that we hear about from health economists of all stripes, left, right, and center, as to what we can do about this problem of cost. And I'm going to try to explain it in one sentence, which is it's easy to waste other people's money. The first thing to understand about the U.S. healthcare system, and I'm going to take it a little bit, to try to look at this from a 10,000-foot vantage point, as opposed to really digging into the Massachusetts. I think David did a great job there. We have to understand that the U.S. healthcare system isn't actually a system. It's what a lot of people are calling a kludgocracy. It's 6 overlapping systems that don't really interact with each other, right? So we have single-payer systems for the elderly and for the poor and disabled. We have a heavily subsidized employer-sponsored system in which we don't actually shop for our own insurance. It's provided for us by someone else at a heavily tax-subsidized rate because we don't pay income tax or payroll tax on the value of our health insurance if we get it from our employer. Then there are the poor schlubs who have to buy it on their own outside of any of those systems. There are the people who will get subsidized insurance through the AC exchanges, a system that you are familiar with here in Massachusetts. And then there are the people who don't bother to get insurance at all and either pay out of pocket or rely on charity care or government mandates to get care in the emergency room. But this is an important point. So there is no element of the U.S. system that isn't touched by government. So there's the thing you hear a lot about in healthcare debates is, well, there's the U.S., which is this free market system, which spends an enormous amount of money and is really cost inefficient, spends too much, has low life expectancy. The U.S. is this free market, it's bad. And then there's Europe, which is single payer, it's universal coverage, and it's much better, it's much more cost efficient, they spend less money. The important thing to understand is we in the United States do not live in a free market healthcare system. We live in a system that's actually roughly half single payer, half quasi-private, of which actually the people who think they have private sector, free market insurance really don't. because they're getting insurance from their employer at a heavily subsidized rate, heavily regulated by the government. And again, when you're not shopping for, economists always talk about third-party insurance and how third-party insurance leads people to spend more, right? Because if you have insurance, you're not as cost sensitive, you're going to consume more. But we don't just have third-party insurance. We have third-party purchase of health insurance. 90% of Americans who have health insurance don't buy it for themselves. They get it from their employer or the government. And so we don't actually have third-party insurance. We have ninth-party insurance, right? So that's not a free market system. So there are, of course, systems that are less market-oriented in the United States. The most famous example is the UK, because in the UK, pretty much everything is owned by the government. So that's truly, when people talk about socialized medicine, if we really want to be technical, socialized medicine is what the UK does because the government controls everything. A single payer system where the doctors and hospitals and the pharmaceutical companies are still private is not exactly a socialized system in the way that the UK is much more consistent with that definition. There are some systems that we think of as more socialized than the US, like France, that aren't really. If you actually dig into the French system, it's perhaps more to the left of us in certain areas. There is, again, universal coverage that is sponsored by the government. But there's also, the government in France sponsors a very basic insurance plan to which you can buy supplemental insurance, which is actually less regulated than insurance products are in the United States. And so the French system, actually, if you total it up, you could make the case that the French system is about the same in terms of its market orientation, possibly more market-oriented than the U.S. is. And of course, I shouldn't say of course, but there are some countries in Europe and around the world that have more market-oriented systems than the U.S. The most market-oriented system in Europe is that of Switzerland. So in Switzerland, there's a premium support system, a term that we've become more familiar with here in America, because the Massachusetts Connector, the Obamacare exchanges, the Paul Ryan Medicare plan, they all rely on the same idea, which is the government gives you a subsidy, which you then use to shop for an insurance plan. That insurance plan's design and content is regulated by the government. It may contain a certain set of benefits that the government has defined ahead of time. It may have certain cost-sharing features that the government has defined ahead of time, and other things in order to have what people would consider a functioning market that makes sure that everyone's in the same risk pool. And so that's not exactly a libertarian utopia. It's what we might call a regulated market system, but it's certainly more market-oriented than the U.S. because there's no public option in Switzerland. There are nonprofit insurers, but we have nonprofit, in Massachusetts, all the major insurers are nonprofit. That's not a system that's necessarily foreign to us. It's not government-sponsored, it's not government-run insurance, but it's government-subsidized insurance. But people shop for their plans themselves. And that makes a big difference in Switzerland. So about 40 to 50% of Swiss citizens have high-deductible health insurance with health savings accounts, for example, something that isn't true in countries which don't have as market-oriented a system as Switzerland does. Then there's Singapore, which is arguably the most market-oriented healthcare system in the developed world. So in Switzerland, they have a very interesting system. They have single-payer coverage for catastrophic insurance. So if you get hit by a bus, that's covered by the government, 100%. But for routine expenditures, there's a mandated health savings account. So kind of like we have with Social Security here, there's a payroll tax of about 20% of your income, depending on your income level, and that then is refunded or rechanneled into a health savings account, which you then use to shop for most non-catastrophic health expenses. So you could say to the left of the U.S. in the sense that they're requiring you to save for your own health care in a way that we don't really here. But at the same time, there's a very consumer-oriented element because you're encouraged to shop for your own care, and you have an economic incentive to stay healthy. Because if you're saving for your own care and that savings accumulates over time, then you're the one who benefits if you stay healthy in a way that isn't true in a system where the insurance products are much more comprehensive and cover much more aspects of the consumption of healthcare services. So, another thing you hear in the healthcare debate is, well, we've got to get this cost curve under control, and we've got to do that using European techniques. European policies, because in Europe they do a great job of managing healthcare cost growth, and we do a terrible job here in the U.S. So here on this chart, you see the growth rate in national health expenditures for four selected countries. The green line is the US, the red line is Switzerland, the blue line is the UK, and the black line is Canada. If you notice any trend there as to which country is doing the best job of bending the cost curve, I invite you to tell me, because I can't really see one. The US curve is maybe a little less jaggedy than the others, but they're all roughly in the same ballpark. And you'll also notice that for all the news coverage of how the U.S. cost growth trend has decreased, which is true, it's also decreased considerably over the last couple of years in other countries. In fact, throughout the OECD, throughout the developed world, the growth in health expenditures has gone down. So keep that in mind when we think about what's going on with cost growth. It's highly probable, shall we say, that a lot of this has to do with the global economic slowdown. How much of this has to do with organic reforms in the United States is at least unclear. So here's the slide I like to give to conservative audiences. So again, there's a lot of conservatives. You hear this all the time, and Republican politicians will say this, conservative audience will say this. They'll say, America has the freest healthcare system in the world, the best healthcare system in the world. And it's certainly true that there are certain things that the U.S. does very well, especially if you actually have health insurance. But this slide is actually mapping out government spending per capita in the wealthy countries in the world. So you'll see here that the United States, is the red bar, the fourth from the top. But because Luxembourg's data is 1 year older than the rest, the United States government entities spend more per capita on health care than all but two other countries in the world, Norway and the Netherlands. So Norway spends $4,607 per capita, Netherlands $43.32, and the U.S. is at $39.67. So all these countries that conservatives think are these socialized countries that spend way more money than us and are completely nuts about undisciplined spending. Let's take France, $30.61. Canada, $31.58. UK, $28.57. Right? So these systems that have more government control actually spend less money. And that's the thing you hear a lot in health reform debates, right? The U.S. is this profligate country because it's free market, and if we were just like the UK and Canada, we'd be more efficient. But wait. Look at those two red bars at the bottom there. Switzerland spends $1,628 per capita on health care, government entities. And Singapore, $762. So the public entities in Singapore, and the Singaporean government spends $762 per capita on health care. They have universal coverage and higher life expectancy than the U.S., and also they're wealthier. It's a wealthier country per capita than the U.S. So we really have no excuse for the level of inefficiency in public spending in America. And again, I say this to conservative audiences, say conservatives should not be complacent about and think that we have this free system in America. We're actually spending way more money than we should. We could cover everybody in America. Remember, the ACA still leaves 30 million people uninsured. We could cover everybody in America and spend a lot less money than we do. That is government spending. And so we should be really thinking a lot more about how to do that, because if we did, we'd solve all the fiscal problems that we have. Now, I know that a lot of people, particularly on the left, say, well, who cares about public spending? What matters is overall health expenditures, because the distinctions between public and private health expenditures isn't really that important. What matters is how much we're spending as a whole, because that tells you whether the system is really affordable. And here the United States, of course, performs very badly, because I already showed you the chart about public spending, and we also have a large private sector that spends a lot of money on health insurance, right? So there, we're terrible. But again, look at Switzerland. So one of the criticisms you'll hear of Switzerland as a model for the U.S. is that the Swiss spend a lot of money on health care overall, even though the public spending is as a percentage lower. So what this chart is measuring is health expenditures per capita as a percentage of GDP per capita. Because, of course, wealthier countries will want to spend more on health care. Health care is a basic good, but it's also a luxury good. So it's just a natural thing. You see wealthier countries spend more on healthcare because when we're all wealthy, what do we want to do? We want to spend it on our health. We want to live longer, right? So if you look at Switzerland here, all these countries in the middle of this chart, that's basically all of Western Europe, right? And so Switzerland, as a free market country, is spending about the same as a percentage of GDP as the rest of Europe. Europe isn't. The single-payer countries aren't more efficient or less efficient in terms of regulating the cost or how much we're spending on healthcare as a percentage of the economy. They're about at the same level. So there's really no difference. The U.S. is way out there as an outlier, but that's not because the U.S. is more free market. It's just because the U.S. has this clodocracy, as we've talked about. And again, look who's at the bottom, Singapore. So Singapore total health expenditures is 2.5% of GDP per capita. Per capita spending is 2.5% of GDP per capita, whereas in the United States it's 17.1%. Right? So we're spending about 7 times as much as Singapore as a percentage of our economy overall. Why? And why is it also that these single-payer systems haven't actually been as efficient as we've been led to believe? Well, one thing that you hear a lot of people talk about is administrative costs. So the common point you hear a lot in health policy circles is, well, Medicare has an administrative cost of 3%, and private insurance companies have an administrative cost of 15% or 12%. So that means Medicare is more efficient. There's a problem with that. There's actually a lot of problems with that, but let's stick to one of those problems, which is that Medicare serves people who are, by and large, over 65, an older and sicker population. Private insurance primarily serves people who are younger than 65, a younger and healthier population. So the average amount of health expenditure on older people is much larger than the average amount of health expenditure on younger people. So you see here the blue bars are the average amount of spending per beneficiary in Medicare, and the orange bars are spending per beneficiary for private insurance. You can see it's much lower, right? So if you actually look at the amount that each of these programs is spending on administration per beneficiary, yes, as a percentage of overall spending, it's a lower percentage for Medicare because Medicare is spending a lot more money. But if you look at the actual administrative costs per person, Medicare actually spends more. Medicare spends $509 in 2005, I should say, spent $509 per beneficiary compared to $453 for private insurance. And that's not even taking into account all the accounting advantages that government programs have in the way they shift around some of their expenditures and administrative costs. For example, the fact that the IRS is the one that collects the premiums and not the Medicare program. Now, I know Charlie Baker was called out once before today, so I hate to do it twice, but Charlie once had this great comment he made about the Partners MGH merger. He said it was like throwing a grenade on the other end of the boat and having it roll back to your end of the boat and blowing you up. And this is what hospital mergers have done to the healthcare system in America. So this is actually a 10-year-old chart. But what this shows is that hospital mergers have consistently continued to happen. It slowed down in the late 90s and early 2000s, but it's picked back up again. So this is, again, a 10-year-old chart. And this top bar, the light green bar, measures something called HHI. It's called the Herfindahl-Hirschman Index, which, to those of you who are economists or follow other industries will know, is a measure of market concentration that's used by economists and also by the government to look at antitrust situations. So in other parts of the economy, like when United and Continental merged, or American and US Air is the most recent one, right? The government will look at it and say, if the HHI is above 1,500, then we're going to go in and litigate, because that's too concentrated of an industry. Well, the FTC and the Department of Justice, the Federal Trade Commission and Department of Justice, have a much higher threshold for hospitals. They only try to litigate in hospital markets where the HHI is 2,500. And now, this chart's 10 years old, the median hospital market in America is above a concentration of 2,500. So even though the FTC and the DOJ use a much higher threshold for hospital concentration than they do for other sectors of the economy, the average hospital market in the United States is too concentrated. And yet, because of favorable court decisions or unfavorable court decisions from the standpoint of the FTC and the DOJ, favorable to the hospitals, a lot of these mergers have been allowed to continue. And what has that led to? A lot of increased price, a lot of market power that private insurers and even government payers have not had the ability to negotiate against. This is the biggest driver of health costs that very few people talk about. More and more people are talking about it. And here in Massachusetts, Martha Coakley has done great work raising this concern, and I salute her for that. But across the country, You hear a lot of people talk about how hospital mergers are going to increase quality and reduce cost. Never happens. Quality is the same, and cost goes up. One study out of California, the University of California, found that in markets that had hospital markets that had above average concentration, according to HHI, prices for routine procedures like knee replacements, cabbage, were 40% higher on average than they were in unconcentrated markets. Price is what this is all about. Hospitals are using their pricing power to market power to raise prices, and we have to do something about it. So what do we do about it? Well, we've heard from Professor Cutler some of the remedies that Massachusetts has chosen. And it may be that really once the train has left the station, the horse has left the caboose, and all we can do is engage in a lot of technocratic micromanagement to try to address this problem. But it isn't the most efficient way to address the problem. Now, it is something actually that I should mention that Singapore and Switzerland both do. So Singapore and Switzerland, which I've saluted as these market models, they do actually aggressively regulate rates. So it may be that this is an inescapable endpoint for all industrialized healthcare systems. But having said that, we would do much better if we could actually have competition among providers and people shopping for their own care. So people could look at 5 different places where they could get a knee replacement. And because they had a health savings account, they'd have some economic incentive to go with the highest quality, best value provider. That doesn't exist today, as we all know. But that would be my ideal approach. There's another approach, of course, which is to go the single payer route, because if you have a single payer, whether it's a private insurance monopoly, a cartel of insurers as you have in Switzerland, which negotiate jointly with hospitals, or a single payer system like Medicare for all, to be quite specific, you could maybe have the negotiating power to fight against these hospital monopolies. So it's monopsony versus monopoly negotiating with each other, and thereby there'd at least be a level playing field. That's one approach. My approach is, let's fragment everything. Let's have competition among the providers. Let's have competition among the insurers. If we did that, we'd have much more cost-efficient care. Unfortunately, we're a long way from that approach. But that's an approach I think Americans would prefer. That's what we're used to seeing in everything else that we do. We don't need to have one place to buy our groceries, or one place to buy our cars, or one place to buy our homes. In theory, we like to go to a lot of different places and compare prices. We should be able to do this in healthcare. Thank you. David, I thought, again, did a great job talking about Chapter 224, and he knows a lot more about it than I do, so I'm going to defer to him on a lot of the details. I want to give some notes of skepticism. I think there's a lot in 224 that's constructive. There's some things that I just want to, again, be a bit cautious about. So there's a global budget in Chapter 224. And we know from the Medicare experience that global budgets don't work. We've had a global budget in Medicare for 16 years. It hasn't done a thing. In fact, all we do every year in Congress is debate the doc fix to get around the global budget for Medicare. So global budgeting has not been a smashing success anywhere it's been tried. And if you think about it, it's like this. If you go out to dinner with 8 people and you all agree beforehand to split the check, are you going to be incentivized to be more frugal in what you order or less frugal? I guess it depends on whether you like your friends or not. But a lot of people will be like, oh, I'll get the 24-ounce porterhouse because, hey, we're splitting the check. And that's a large part of the problem here is if you have a global budget, but individual physicians and providers have no incentive to be cost-oriented, it really doesn't matter. So that's why global budgets don't really work. The design of the law may incentivize low-cost providers to raise prices. So part of the way the law is structured is to create a median that's the average price for something and try to discourage people from being outside of that range, right? But what does that also do? It may discourage people from overcharging relative to the median, but it also discourages people from undercharging relative to the median because they know they won't have any punishment for doing so. And they won't really get a benefit from having lower prices. So once they know what everybody else is charging, they can actually raise prices. Another point is ACOs. So ACOs are the thing that everybody talks about in healthcare. Accountable care organizations are going to provide integrated care. It's going to be so great. And look, it will certainly help improve the delivery of care. There can be no doubt about that. But will it lower prices? Almost certainly not. Because what ACOs by definition require is consolidation of providers. And we've already described how consolidation of providers increases rather than decreases costs by giving providers market power to dictate prices. There are some loopholes in the way the law is structured in terms of the fact that the government can define exceptions for some of these cost control elements, which are the kinds of things that lead to regulatory capture, we call it, where skillful lobbyists who know the regulations better than the bureaucrats do figure out how to game the system or convince people to modify the regulations accordingly. Hospital procedures, as we all know, if you've managed to wade through that Time article by Steve Brill, it's so complex. There's a lot of things that hospitals can do to get around the cost controls by charging more for this thing and less for that thing in order to meet a regulatory mandate that can't be as dynamic in the way it changes in the way compared to the way a hospital can modify its pricing structure. I will say I'm particularly encouraged, and Josh Archambault is one who's pointed this out to me, that about the malpractice reforms in the law, which I'm encouraged by, and I look forward to seeing how they progress and if they have any impact on defensive medicine. But the bottom line is that the best way to control costs is to do it yourself. If you're spending somebody else's money, you're much more likely to waste it because you have much less incentive to control someone else's spending. If you're on an expense account, if you're at an open bar, if you're dining out with 8 friends and splitting the check, we all know how that goes. And that's exactly what happens in healthcare. I think a lot of people in the healthcare world seem to believe that healthcare is immune from the laws of economics, but it is not. And this is the part of the problem. A lot of smart people puzzle about why healthcare is so expensive. It's because for so long we've decided that the laws of economics don't apply to healthcare, and they do. So if we give people more opportunity to shop for their own care, I believe they'll do better. Now I'd like to just touch on, and I'll conclude with this, two criticisms of a consumer-driven approach that are important to address. The first is that people are dumb. That people aren't wise enough to make the best decisions for their own care, and we need disinterested experts to do it for them because otherwise they'll be exploited by opportunistic companies, insurers, pharmaceutical companies with their drug ads, et cetera, et cetera. And look, that is true that not all consumers are informed. But what we know from markets generally is that it doesn't take that many consumers to drive a market. So if you have something in the general economy, say car manufacturers, and because one guy's car, GM's cars are 5% worse, have 5% less share than Toyota's cars, because Toyota's cars are better, and that small segment of the consumer population is reading consumer reports and reading J.D. Powers, they're driving that little bit of market share. That has a huge difference in the profitability of Toyota versus GM. It means Toyota can reinvest more in innovation, in lowering prices, and thereby expand its lead against GM. And then it separates and separates and separates. So it only takes a small percentage of the market to be sophisticated consumers to drive massive change because businesses realize that that incremental consumer is so important in its survival and its success. So it's true that many Americans are dumb, but it's also true that many Americans are smart. And the smart ones will actually help make the system more efficient. The last critique is that if you have a consumer-driven system, because people are spending their own money, they'll have an incentive to not spend on things that will help them in the long term. They won't do the preventive tests. They might skip on their medications because they'll save money that way. And that is also something that we should be concerned about. Studies of health savings accounts have shown that most of the people who actually use them are pretty good about preventive care. And there are things you can do with the design of insurance plans to encourage that more. You can have more first dollar coverage of cost-effective preventive services that help prevent people from that cost problem or that risk problem or whatever you want to call it. So there's more work to do, but I think if we keep in mind that fundamental principle that it's easy to waste other people's money and it's harder to waste your own, we'll have a much better healthcare system. Thank you.
Well, thank you. You certainly gave me lots of homework to do, listening to all of those perspectives. I think I'm going to start with an easy question and actually a chance for Dave Cutler to respond a little bit to this notion that that ACOs encourage consolidation and therefore exacerbate the problem of market power on the provider side. And I think I'd just like to hear your perspective. Now, right now, many of you may be aware in Massachusetts that our highest priced providers command about 40-50% of the market. The four or five highest priced systems, that's where everybody wants to go in our market right now. Now, we got there through a market-based system, through people choosing where they wanted to go, and because they chose that, they often chose very expensive systems, but partly because they weren't paying for it fully, as you've mentioned. But maybe, anyway, David could mention a little bit about what he views as the state's likely tool set or thoughts about how we will deal with consolidation and market power going forward, because I know it is a key issue that the Attorney General and many others have highlighted.
Thank you, Nancy, and thank you, Avik. It is a very big issue. It's a bigger issue for private insurers than for public insurers, because public insurers don't negotiate prices, they just set prices. So when Partners forms or buys another hospital or whatever it is, they just say, look, this is how much we'll pay, and using whatever rules they use. But consolidation is a very, very big issue for private insurers. I second the idea that we need a stronger antitrust system. The Justice Department in the Clinton administration used to say that it won every antitrust case it lost, except for healthcare, where it won every antitrust case it brought, except for healthcare, where it lost every antitrust case it brought. And that then continued. In the Bush administration, they didn't really do anything about it, and finally, you're getting a little bit more invigoration of it now in the Obama administration. I would say we're going to do a couple things about it. One is, in Massachusetts, it was believed that the Attorney General's reports were very important, and what Chapter 224 did was it tried to, in essence, increase the amount of that. So it made those kinds of reports statutorily required. The commission that I'm on, if a provider or a provider system is getting bigger in some way, there's required to be a study of it done that would then feed into the antitrust process, so there's no formal action that comes from it, but feeding into the antitrust process. So there were a variety of things on the one hand to try and address the antitrust issue. On the other hand, the state has been very, very big, and I want to second something Avik said, very big on trying to give consumers incentives to move out of those very expensive institutions, particularly for routine care. One of the interesting things about insurers here is insurers in Massachusetts were very slow to introduce products that priced expensive institutions very high. And many of them introduced those products only because the state required it. So about 2 years ago, the state required it through legislation that insurers introduce a kind of tiered network product with savings of at least, I think it was 12%. And the insurers, most of them sort of grumbled and went along with it. And then it turned out they're the most popular products in the state. And so now they can't sort of roll them out fast enough. And they're particularly popular for small businesses, not big businesses that don't particularly want to be there yet, but small businesses that are looking for a lower price point. And so the state is sort of really putting a lot of effort into doing that. We introduced them to state employees an enormous amount there. Expanded, the 224 legislation expanded them some. And it's sort of an idea to try and get the use of them much more widespread. Now, they're not, for the reasons Avik said, they're not sort of always good. That is, there are people who, if you have if you pay, $1,000 to give birth at Partners Hospital and, at Brigham Women's Hospital and $20 to give birth at Mount Auburn, people will go to Mount Auburn. But that will be true even if it's a high-risk baby, even if it's a high-risk mom. There are people who will do that because they just can't afford the $1,000, whether they have an HSA or not, they just can't afford the $1,000. And what you want to do in those circumstances is say, look, if you're a high-risk mom, you don't pay more to go to the Brigham. But they haven't found a way to differentiate those yet. And so the state is pushing the insurers to try and find a way to design these in a smarter way that says, look, for anything that's routine, you got to pay more for the more expensive place, but not if it's sort of super specialized. It's an area where I would say, actually, the private sector has been doing a lot, but it's been doing it in part because the government has pushed it a lot. And so I think both of those avenues are very big ones for the state, because it is the general question about how do you take advantage of consolidation where it's really good, which is in helping to make things more coordinated, but avoid the bad parts, is something that's absolutely fundamental both to state and to antitrust policy in general.
Great.
Maybe I'll just add one comment. I agree with everything David said. I would just also add that to your point about that there was a free market that created the consolidated hospitals that we have today. That's not true in a couple of ways. One, or at least I would contest that assertion in a couple of ways. The first is that most states, and Massachusetts is one, have what are called certificate of need laws. You have to, if you want to start a new hospital to compete with the existing incumbents, you have to go through this incredibly bureaucratic process that's driven in part by the hospital lobbies. So there's an incumbent protection racket that goes on under the name of certificate of need laws. Now, I understand that there are alleged policy justifications for certificate of need laws, because if you have too many hospitals, maybe they would compete with each other and go broke or something like that, and that would be complicated and problematic. But that's again how most of the economy works, and it's okay with hotels, say, and maybe not. So it should work with hospitals. Another point.
Can I just interject one thing, because it came from your presentation? In this state, we've gone from 108 hospitals in 1980 to about 60 hospitals now. So our problem is not. I mean, nobody wants to build a hospital here. They want to close them down. And we probably still have 20 hospitals too many. So actually, the certificate of need is not a binding issue in this state. It may be in other states, but it's in here it's not.
Well, I would make a point to that, which is that part of the challenge for incumbent hospitals is because of their fixed costs and labor contracts, it's very hard if you're a hospital to adapt to changing circumstances, changes in, for example, length of stay, in the types of procedures that are being, you're getting hospitalization for. New hospitals, new entrants can be more adapted to the healthcare delivery system of today. And so it's one thing for old hospitals to close. Old car companies close too. Things close all the time, but the problem is things are closing without but new entrants coming in. And new entrants would come in if they had more opportunities to do the kinds of things. For example, I'll just give the example of Jonathan Bush, who was the cousin of George W. Bush, who started a company called Athena Health that maybe some of you have heard of. His first attempt at a business was to start ambulatory obstetrics clinics where he'd deliver babies. He couldn't do it because of a certificate of need laws. He wanted to say, you know what, I'll set up shop across from the local general hospital and charge half of what the general hospital charges and save everyone money. He couldn't do it because the certificate of need laws prevented him from doing so. So the entrepreneurs who want to deliver healthcare more efficiently by building new institutions from scratch don't have the opportunity to do so. And so that plus the closing of incumbents that don't structure themselves well leads to the consolidation.
Actually, just on Athena Health, because I just taught a case on that and have done a lot of. I find it a fascinating, it's a great company, great star, wonderful to have in Massachusetts. It actually did have those obstetric units, but they had mostly Medicaid patients and they basically couldn't make ends meet. So I think it really wasn't, and it was working in California for a while, but they actually couldn't manage the cash flow problem of dealing with Medicaid, which is, as you've pointed out, is a terrible payer. Let me just ask Avik a question related to some of the other items of issues that you were talking about, and I think one of them is that you think people should just be paying directly and ideally eliminate a lot of the poor incentives that you have when other people help you pay your bills. And I guess my question is, what's insurance in your mind? I understood insurance back in the day, whenever my ancient education occurred, that insurance was having healthy people pay for sick people. And the point was to spread that cost, because when a person actually got sick, their individual bill would be well past, way more than they could afford. And I was a physical therapist, actually, before I went to business school, and I actually got to observe that firsthand because I got to see uninsured people and what happened when they got the bill. And they actually couldn't pay the bill, and many of them stopped their treatment. And actually had much worse health outcomes for it. So they were paying as much of their bills as they could, but then they had to stop. And there's a lot of research that says that people who don't have insurance have much worse health outcomes, much shorter lives, and have greater disability and lower lifetime productivity. So what is insurance if it is not to get healthy people to pay for the sick? And then how do you decide that, what's enough of your income to be paying if you're not insured and getting support from healthy people?
So I have a more conventional definition, view of the definition of insurance, and that is that insurance exists to protect oneself from catastrophic risk. That's why we get car insurance. We get car insurance so that if we crash our car gets stolen, we can get reimbursed for that. We get homeowners insurance, so if our house gets on fire or gets flooded, or is robbed, we have a protection against that. We don't get car insurance to pay for gasoline or wiper fluid or oil changes. And yet that's what we think that health insurance should do. And that isn't what health insurance should do. Health insurance should be there for when you get hit by a bus, or you have a stroke, or you have cancer, and then health savings accounts should be for the rest. Now again, if you look at the Singapore model, they've shown that it can work, that it's massively more cost efficient to do it that way. You can subsidize the health savings accounts for lower income people to ensure that they're protected and have the same access to care as everyone else. So it's not a matter of leaving everyone uninsured or leaving everyone unprotected or leaving the poor on the streets. It's actually quite the opposite. But by giving them the opportunity, by giving them the money directly and putting them in control of their own health dollars, they will consume more effectively.
And the definition of catastrophic?
Well, it depends on what you're talking about. If you're talking about cars, obviously we think of it as crashing your car, right? For healthcare, the way the Singaporeans describe it is, as I said, it's for things like having cancer, getting a stroke, getting hit by a bus. It's things that cost a certain level threshold of money or a certain sudden kind of attack. You have a stroke, you have a heart attack. So it's things that are less predictable, but that are sufficiently risky that we all want to take out that kind of insurance.
Dave, do you want to respond to that at all?
I don't want to disagree because I don't think this is a great forum for enormous disagreement, but let me just give, just not fun, but let me just give a couple of comments. One is one is consumers are price sensitive, so we know that very clearly. Second is that all the studies that I've seen, maybe there are some I haven't seen, but all the studies that I've seen show that when people pay higher prices, they cut back on services pretty indiscriminately. Yeah. They cut back on valuable services and they cut back on not valuable services. And that's true in plans where they've carved out the preventive care. It's true in plans where they've done whatever. It's just people are not, it's not a few people are dumb. I actually don't think they're dumb. It's that people are very, very sensitive to current prices. So just to give you an example, if you take someone who's on a chronic care medication, the doctor says you should take this high cholesterol drug, every day for the rest of your life because it's going to cut your heart attack risk by an enormous amount. And they're paying, $5 a month at the pharmacy for it. If you raise the price to $15 a month, and these are people who should be taking it by any rights, they should be taking it. About 10% of people stop taking the drug. They just say, look, I just can't afford $15 a month, even though by any rational criteria they should. Now, they do some things better, like they search for the $400 CT, or more accurately, they say, look, doctor, I'm uninsured. Do I really need this CT? And the doctor says no, and so they avoid it. So that's good, but they also cut back on the things they don't, and nobody's ever written a study that I'm aware of that shows that you can eliminate some of those some of those adverse effects. And I will just one final point to add, which is that the vast bulk of spending is in people who are far above the deductible, or whatever it is. Yeah. So the minimum for a case of cancer is $20,000 up to $200,000 or so, and so you need to think about that, because the vast bulk of that spending is not going to be affected by the way that you do the insurance product. I mean, once I have cancer, I've already blown through my deductible. You've penalized me, whatever, $5,000, I've blown through my deductible. Now what? And if you don't have a good now what in place, that is, if you're not thinking about the way the insurance policy is going to deal with the person, then you're just going to miss where essentially 80% of all the dollars are. So we know that sort of 20% of all the 20% of the people are about 80% of all the dollars, the 80-20 rule. And that's really problematic. So it's a great thing to think about, do people really need the, well baby visit, or could they have done without, or whatever, and you can sort of debate that, but that's not where the money is. The real money is in how do you deal with people when they get very, very sick, and the management of that. And so I think I like the cost sharing in some circumstances and all of that, but I don't think that that's sufficient to address all of the issues, and we know it has known problems.
It's now 10 after 8. I think I should take a couple of questions from the audience, and we have 2 mics if people want to line up and just get on one side of the room or the other and ask questions of our panelists, because we want to have time for Mr. Hewitt to come forward as well. Go ahead.
Yes, I resist the temptation to tell war stories about individual problems in the hospital, and I know that we all realize that Partners Healthcare, who I thought was a non-profit, recently made a $720 million net profit before tax. But anyway, if you go to Newton Wellesley Hospital before Bromley Care, and you do have the catastrophic insurance you're talking about, which is no longer saleable or permissible in Massachusetts, I believe. Am I right? You can no longer buy catastrophic insurance.
There's a minimum level of
you
benefits.
You have to have the regular thing.
There's a minimum level of benefits, but you
so
can
I
have
can go on the connector, and it's $36,000 to get the package, right?
You can have deductibles.
You go on the connector, I'll get my $36,000 plan. But what I was getting at the beginning from the first presentation was this price differential. Well, there are these three prices. So Newton Wellesley Hospital, maybe it's probably about the cost of $100 a night for being in a room. For the insurance company, it's $400. For the person off the street, it's $1,400. And there's something wrong with that. And I say, trying to resist the temptation of having been in there for a couple of days and getting my bill for $32,000, and then finding out that I hadn't had any treatment. There was all these expensive tests. So it's $10,000 for the MRI scans, and it's $10,000 for the... And of course my insurance kicks in and they pay the real price, which is only $800 for the CAT scan. But then I go, and 3 months later I go to the neurologist, and he says, why don't you go back there and just get another checkup? So I go back to the same hospital, and sure enough, the same people, the same test, the same lab, etc., doing the, the MRI and all that, and I get the bill for $10,600. And I then say to the insurance company, well, what about it? And they say, well, no, you're only insured because you're an inpatient, you're not an outpatient. I say, well, I just had exactly the same procedure. You paid $800, I paid $10,000. There's something wrong with that. Surely we have to do something about that.
Do one of you want to try to address that?
Who were you asking?
I haven't paid the bill yet, by the way.
There was Time Magazine recently ran a very long article, I think the longest article they've ever run, by Stephen Brill, which was basically about pricing issues and how opaque it is and how nonsensical it is. And so I think your example, you could multiply by 25,000 words, and you could, and that's what happens. And it's very difficult to figure, you're going to have to be very careful before you just unleash people and say, go deal with it.
It's very complicated.
Yeah, I think that it's an important thing for people like me who favor a more consumer-driven system to be mindful of, is that right now, people who have health savings accounts have difficulty shopping for care because pricing, particularly for hospital services, is so opaque. And that needs to change. And there's an organic way to change that, which is to have more people with health savings accounts, because they will demand more transparency from providers. And you can also have laws that mandate price transparency as well. And I think 224 has, the Massachusetts reform does have some of those provisions. There was a law that tried to get through in Arizona to do the same thing, and it was fought off by the hospitals and the doctors, and actually the insurers as well. All the industry players didn't like it. The hospitals don't like it for all the obvious reasons. The doctors don't like it because doctors don't really want to compete on price with each other. And the insurers didn't like it because they like to have their negotiated contracts with their particular network of providers be kind of a trade secret. They don't want the other competitors to know what rates they've agreed to with partners. So a lot of times people, when legislators in states or in the federal government try to do these kinds of things to encourage more price transparency, they have a tough time. And so I think it's to the credit of the people who worked on the law in Massachusetts that they were able to get somewhere on that score.
On the other side?
Thank you. Oops, sorry. I'm going to start by just saying that I'm a data and an information geek, so I like the charts and the graphs. You're speaking my language. And it relates to, now I'll just tie it into your last point about price transparency. I work in technology consulting for hospitals, pulling information together, and I can tell you no hospital in this country could give you a price even if you mandated it. They couldn't tell you their costs. And so one of the things that I'm encouraged to hear is what David had mentioned about, well, great, we're going to encourage, and I heard you use a 4-letter word, which is real-time reporting. Nothing in healthcare is real-time. At the very least, it's 3 days old based on the diagnosis codes. You can actually figure out what was happened. But what I'm worried about is a lot of the headlines regarding where the industry needs to go is based on information that no one within the industry can provide. Within hospitals, if you want to have a price and cost discussion, you need to start talking to companies like the Epics and the Cerners and the vendors of the world who make money on the disparity and not allowing the industry to actually understand how to tie a lab to an inpatient visit. And so I wonder if there's ever going to be the discussion about actually getting the data together to have these actual real conversations. I joked with a friend who I met earlier that I love the Pioneer Institute because folks like Josh can peel away headlines and call BS what it is and good stuff what it is. And it's with data. I don't see us getting any more capable of actually being able to produce this information to support any of the arguments that we're making.
Yeah, no, I think if the government has a role, I think, in encouraging or requiring the people who generate data to provide it so that more people have access to it for analytical purposes, in my view. Because right now a lot of people, they don't talk to each other because they see it as a competitive advantage. And I can understand that too. They have to run their businesses and you don't want to step on them in that regard. They've added value by compiling this data. You want them to have a business that they've created. But there's somewhere in between, I think, where we can try to use this data more, and I think that the work that David has done here in Massachusetts is a step in that direction. But I'm sure David has more thoughts on that.
We had a number of discussions around data availability in the run-up to Chapter 224. I see David Seltzer. You probably participated in 50 of them, if not more, and they are still ongoing about exactly what data do you give and so on. Some of it's fairly straightforward, like sort of clinical information about patients and so on. Some of it's very difficult, as you said, exactly how much does it cost to provide a service at a typical institution. There's been some great work that was done by Michael Porter and Bob Kaplan of Harvard Business School, and they published it in the Harvard Business Review about activity-based cost accounting and why it's so essential for hospitals and other care providers in medical care to figure out really what you should be doing and what you shouldn't be doing. And I think the unfortunate answer so far is that it's proven to be very difficult to apply it in healthcare because those institutions are so complicated that you just haven't known how to do it. So I know institutions that are struggling to try and do it, but it hasn't been easy to do. And so internally, I think it's just going to take them a while to figure out what exactly do we know about our cost structure, and how do we then optimize what we do in light of that?
I do think that the point of the act in Massachusetts is not to give people how much it costs the hospital. It's how much the plan and they will owe for their particular
How much the cost will be
procedure.
to you. That's
Trying
correct.
to tie that to the cost of the provider is probably
correct.
not in
That's
our
right.
pay
They
grade.
need their costs so they can figure out what's the best way for us to treat this.
But the consumer just needs to know what's going to come out of their own pocket. And there's a huge, as our first questioner mentioned, there's a huge difference
Yes.
between what you're supposed to pay and what the
Yes.
cost structure is. So on this side.
My question is regarding the HSAs.
Can you just speak a little louder, please?
My question is about the effect of HSAs on price sensitivity by consumers, and you mentioned that most of the research has indicated, to date, has indicated that in the U.S. consumers cut down on the services they partake in when they have more upfront costs, but I believe that most of that data doesn't really look at consumers who have HSAs per se. It's looking at patients who are paying out of pocket directly, and so it's out of their current income and the income that they have currently that's not already set aside for health. And if that income is already set aside for health in a health savings account that is automatically deducted, like in the Singapore model, I think that you'd probably have much less of that negative effects. And if you looked at those effects in the Singapore model, you'd probably be able to corroborate that.
I believe some of the studies have compared people with HSAs. Many of them don't, but a number of them have looked at the HSAs, and they find the same thing because, you sort of say, gee, if I don't spend it now, I get it for something later. So people tend to behave kind of the same way.
There are a couple of studies that reflect well on HSAs. There's one by the American Academy of Actuaries in particular that was relatively rigorous that showed, I think, certainly showed price sensitivity and showed less consumption of health care. But by and large, when they broke down what that consumption of health care was, it wasn't, from a clinical standpoint, it wasn't a terrible outcome. They were cutting back on, as you say, things that they should be price sensitive on, but less the things that were necessary. And yes, look, that's always going to be a problem with any sort of system of consumer-driven care that people might forego. But people already do that, right? Like, I should have worked out this morning, I didn't. I mean, this is part of life that we often do things that aren't necessarily in our long-term interests. Having said that, if we make sure that lower-income people have subsidized health savings accounts, so everyone is funded, then we give people much more incentive. Because again, remember, the HSA accumulates over time. So in any given year, if people have a high deductible plan, but their HSA is 3x the deductible because they've saved money over time, then they can consume whatever care they need to in a given year if they're ill or they have a chronic condition. And again, there are ways to structure the insurance plan in order to give first dollar coverage for certain preventive services in order to get around that problem for clinically relevant preventive care. That's what South Africa does to a degree. And so there are ways to address this problem. It's more of a technical problem than a fundamental problem with health savings accounts, I would say.
Yes.
I have one for each of you. Professor Cutler, in your remarks, you mentioned how individual states have come up with interesting plans, some of which are successful. It brought to mind, from the last presidential debate, the question as to whether the ACA or Obamacare, the universal one-size-fits-all, is the best model, or are we better off letting individual states come up with health care plans and seeing which ones we should emulate? Dr. Roy, the Singapore numbers on those graphs look so good. Would we be better off in the United States simply taking their model and emulating it and saying, gosh, what a big step forward, we gain a factor of 7?
Who would you like to go first?
Why don't you go ahead?
Okay, I'll go first. I'd say a couple things. As we know, the Singaporean political system is a little different than the U.S. political system. And so as much as I might love to have the system that Singapore has healthcare-wise, we can't be certain that in our system of government it would stay that way. It might be affected by the politics, domestic political system here. Lobbyists might get in charge of it and require certain things or make changes to it. There may be agitation to change it in certain ways. We just don't know. I think economically it makes a lot of sense, and I use it in particular to illustrate what consumer-driven healthcare could do. I think a more realistic model for the United States is Switzerland, because the ACA exchanges and the premium support plan that Paul Ryan has proposed and Mitt Romney proposed in the last campaign are very similar to the Swiss model. And so Democratic politicians, leading Democratic politicians and leading Republican politicians have all supported a model similar to the Swiss system. So we could, in theory, migrate the Medicare population and the Medicaid populations into the Swiss system and have basically a universal exchange that covers everybody with a heavy emphasis towards subsidizing lower income people. And while that wouldn't be as cost effective as Singapore, it would provide more cost effective care than we do today in a system that covered everybody. So that's, I think, politically a more attractive model for those reasons. But look, I mean, if we could come up with a sustainable way of having a system like a healthcare system like Singapore's, I'd certainly be in favor of that.
I think that your question hits on a central issue, and I wish more governors would have listened to Avik, because what he basically said was, look, we can, and what you said is, look, we can have experimentation at the state level. The Obamacare says we'll make it affordable for people and we'll make it accessible through these exchanges, but then the actual operation of the exchanges is something that was in the legislation designed to be left to the states to figure out how best you run something like this in Texas, and is that different from the way you run it in Massachusetts. And I think that I would have loved it if they'd listened to Avik and taken the ball and said, you know what, this is giving us a lot of authority to influence how we best design something for our citizens. And instead, most of them were so upset that they just said, no, we're not going to run it, and we're going to leave the federal government to run the whole thing. Which, I don't know, I would rather have seen them, who are closer to it, do it. And so we will have more of a federal system than was designed because the people who don't like it won't participate.
We should, our time is getting a little short, so I'm going to take 2 more questions. If you don't mind trying to make your question very concise so that we can have Mr. Hewitt come up and give us some closing remarks.
I'm sorry.
Go ahead.
You were finished. I'm just wondering if either of you are familiar with the healthcare system of group health in Seattle, Washington, and or the system that's in Atlantic City with a gentleman who's from Harvard, but I could never pronounce his name, and what your thoughts are on those systems.
Group Health Cooperative and the Atlantic City system share many features in common with what's done at, say, Kaiser, or what's done at the Mayo Clinic, or what's done at many other places across the country, which is that they provide extremely good care at much lower resource utilization, generally lower cost as well, though some of them price very high, but generally much lower cost as well. And the way that they do it is exactly the ways that I was trying to sketch out, which is they take themselves away from the model, which is, gee, I get reimbursed by doing procedures, so I'm going to do procedures. And instead, they move themselves into a model that says, my goal is to take care of this patient. And when this patient is healthy and not using and doing things the right way, then they're going to be happier and cheaper. So if you look at, for example, where the information systems are the best, Kaiser spent $4 billion on an information system. If you look at where chronic care, care for diabetes and high cholesterol and mental illness and so on is best, Group Health Cooperative has pioneered the models for that. If you look at where coordination across specialists is the easiest, and where do you go for a very quick consult? You go to the Mayo Clinic and they just walk you down the hall and so on. And those are all examples of organizations that have said we're going to be more efficient, and the way that we're going to do it is not to say, we're going to make the person pay a fortune or whatever, but to say we're going to deal with them the right way every time, and the money is just, it's there in the background, but it's not driving what they do. So those are absolutely fabulous systems. You can save a lot on the acute end because you don't get people in those circumstances where they need the very expensive things, and people wind up being very happy.
Did you want to respond, or
No, I think David answered that.
Okay, last question then.
My question is regard with pharmaceutical companies, and I know you really haven't included the cost of drugs as one of your major items, but as an oncologist over the years, I do quite a lot of studies for pharmaceutical companies based on new drugs, and one of the classic questions that they ask, and this is A, B, C, D, E, is if we charge $1,000 for this new product, $3,000, 2 to 4, $5,000, will you use this drug? They are looking for the highest price possible. Mm-hmm. And the new drugs that are coming along in my field are enormous. The long shot is that many of them are equivalent, many of them are not that effective, but they go through testing. And I think that is a huge piece of the, the financial drain, at least in this kind of a field. And it overlaps, I'm sure, to cardiac medicines and others. And that's something that we have very little control over. They will charge whatever they think the traffic will bear. And the question is, how do you, interfere with that? How do you deal with that?
So in my past life, before I started blogging and pontificating about healthcare policy, was as an investor in pharmaceutical and biotechnology companies. So I spent a lot of time studying just this problem. And first, let me just leave some background, set some background, which is we actually, in many ways, have the most efficient pharmaceutical market in the world. So in the U.S., more so than any other developed country, if a drug goes off patent, there's an immediate flip, and the market becomes commoditized right away. Literally, for most generic drugs, it is cheaper to manufacture a prescription of generic Lipitor than to make a can of Coke. So for small molecule drugs, which is conventional molecules, not proteins, protein therapeutics, we actually have a reasonably efficient system. The problem with the branded price initially is particularly acute in oncology and some other areas like oncology, because of the way we pay for those specific drugs. So most people who have cancer are old people. So old people are on Medicare. And Medicare basically pays whatever the drug company charges, because if we have not, as a country, wanted to give Medicare the power to negotiate prices with the drug companies. It's also another area where drug companies have enormous pricing power is for ultra-orphan diseases. So if it's a disease that affects 4,000 people in the U.S., whether it's a patient with lung cancer with a particular mutation that, again, 4,000 people in America have, or it's a childhood genetic disorder that 4,000 people have, companies have said, well, we have to charge $300,000 per patient per year for that drug, because that's the only way we can justify our R&D expenditure on the front end. So could we do better in all those regards? Yes. If we migrated some people would say, let's have the government directly negotiate for prices for Medicare. I would say migrate it all into Part D, the prescription drug benefit, which has done a great job introducing market-oriented negotiation into drug pricing. So Medicare Part D has stratified drugs, so just like with private insurance in the conventional market, if there's a generic drug that's just as good or almost as good as a branded drug, start on the generic drug. Cancer, it can be the same way. So there's a lot of things we can do, because right now what happens is injectable oncology drugs and injectable drugs, for the Medicare population in general, are paid for not by the Medicare drug benefit, but by the traditional Medicare program. So there are things we can do to reform that by making sure that the incentives are more aligned. But broadly speaking, we do a better job than most countries, because if you actually look at Europe, say, with those ultra-orphan medications, in Europe, drug companies get higher prices than they do in the U.S. So it's not like the Europeans have done a better job with this. And actually, if you model drug revenues for any kind of drug in the U.S. versus Europe, roughly the same size population, the net present value of the revenues and profits that a company generates in Europe over the life of a drug are much higher than they are in the United States. Because in Europe, when a drug goes off patent, there isn't that cliff where the generics come in and take over the market. There's much more of a long tail because of the inefficient way in which European countries have regulated their generic markets. So there are certain things we do quite well, and actually drug spending as a percentage of overall health expenditures has declined over the last several years because of that efficiency. So there are a lot of good things. There are some things we could improve.
I'll just add very quickly that the single hardest problem in the health economics, in economics of healthcare, is basically what do you do about Avastin, which costs $93,000 or whatever it costs, or Provenge $93,000, and extends life by 4 weeks. And it's blown through every deductible you've had, so you're never going to give a person a choice. Congratulations, you can pay $93,000 to extend your life by 4 weeks or not. So you're never going to do that. how you're going to price the thing, how the government wants to decide how to price it, how much to reimburse for it, and so on, is just incredibly. Once you have competition, you can then think about how you set up the market for Avastin versus Zaltrap, and for patients with metastatic colorectal cancer and all of that. But when you just have the one of them, it drives economists who love markets down the regulatory path for at least that one little carve-out part of it.
I think we should allow Mr. Hewitt to make some closing remarks, but this was very educational. Thank you very much.
Yes, thank you to our panelists and our moderator for their comments. And at Pioneer, 8:30 means 8:30. On the other hand, when we have a topic like this and people like these folks, they will be around for a bit for people who might want to come up with individual comments. I was a little disappointed when David said this was not the forum for provocative comments. So maybe if you ask him something personal, you'll get something a little bit more provocative. But thanks to all of you for attending and supporting this event. This lecture series began 8 years ago, funded by donations made to Pioneer in my father's memory. Pioneer, seeking an appropriate use of those funds, chose to invest them in this continuing series on health care, which was one of Dad's true passions. Among other things, he served as chairman of the board of the Deaconess Hospital and was a longtime board member of the combined Beth Israel Deaconess that exists today. These annual presentations provide a cornerstone for Pioneer's leading-edge work in the intersection of public policy and healthcare delivery. The Massachusetts plan was passed in the first year of these lectures. Dad never saw that, but I can assure you he would have wanted to be in the midst of it. Pioneer has done just that in the years since. We thought it was going to be a bigger issue in the presidential campaign than it turned out to be. However, as evidenced by the remarks tonight, this does not mean that in the immortal words of Kevin Bacon's character in Animal House, that all is well. Far from it. Focus needs to be maintained on the issue, and Pioneer intends to be one of those providing that focus. As Pioneer's founding chairman, Pete Peters, would always remind us at this point in the evening, we hope that this event has been stimulating to you, and it may cause you to have a generous impulse toward Pioneer. With your help, this series can be continued in the future, and Pioneer can continue its work analyzing and publishing on this fundamentally important issue. Healthcare is and will continue to be a leading subject affecting all of us for years to come. The implementation of Obamacare alone is barely off the dock. It needs to be done under the bright lights of intellectual evaluation. Consider this the electric bill. I hope you will all continue your avid interest in this subject and join us again next year for the 9th Hewitt Lecture.